Good evening, everybody. I think we can start while waiting for the rest. Dr. Chandran, are you okay to start?
Yeah, sure. Can.
Okay.
Right.
You might need to share your screen again because
Yep, I'm sharing it again. Okay. Okay. Right. Hi, everyone. So, Dr. Chandran, first of all, thank you for the JRX Global for inviting me to share. So, this session today started off because we were discussing how to make every general public, those who are not in the imaging field, to understand a little bit about what is different types of imaging we have and how do we use this imaging and how to read the reports generally. So I'm not going to teach you guys like how to become a radiologist. That's not going to be possible. But what we're doing is that trying to give you a small understanding of what type of imaging that we can do, and we're going to go through a little bit of nomenclature, how what when we say some words in our reports, what does it mean. And of course, today's sessions mainly we focusing on lung cancer, but I do have some other cancers which I just show one or two, but mainly for the lung cancers. And we're going to look at what you mean by lung cancer and basic interpretation of the scan reports. When you receive your scan reports, what are things you have to look at and how to determine what is being said to you. So I'll try to do it as basic as possible. There might be some queries later. You all can contact any of my team members, and then we'll try to answer most of the questions that you have. So when we talk about imaging, and we have plenty of imaging in radiology, starting from the X-rays, we call that plain radiograph. We also have ultrasound, CT scans, MRI. These are different type of imaging, and each one has its own role to play, including PET scan, PET CT, which is very popular lately, bone scan, thyroid scan. So when we talk mainly about lung cancers, we're going to focus on three of this, maybe four. The first three is the plain radiograph, CT scan, and PET scan, PET CT. These are very commonly used in the to look at the lung lesions, right? And I'm going to go through why we use each one of this and what is the benefit and in which cases you use them. And do have to understand that each one of these, although all of them are considered imaging, there are some condition where one is superior to the other. All right. So first we look at plain radiograph. All right. A plain radiograph is one of the most common imaging that we have done. I think most of us, when we go to a new job or when they apply, go to university, we always ask to do plain radiograph. The reason why we ask to do plain radiograph, this is the fastest and easiest way to interpret what is the general lung function. All right, it's a very common imaging tool. I think most people have at least went through this at least once. The issue with this type of radiograph is that it uses ionizing radiation. So when you have radiation, there's two types of radiation. One we call non-ionizing radiation, and second one we call ionizing radiation. Okay, to make it simple, I can say that non-ionizing radiation is we can consider them as safe type of radiation. For example, when we talk about MRI, we talk about ultrasound, we're actually talking about non-ionizing, right? But when you talk about ionizing radiation, that means this radiation has a potential to cause damage. Then we're talking about X-rays, CT scans, PET scans, and in some cases we're talking about radiotherapy. All these have a potential of causing injury to the cells, but it always depends on how much energy we use and how many times we do and how frequently we do them, right? But the plain radiograph is one of the lowest ionizing radiation. Therefore, we can use it in general public as a screening tool. Okay, it gives us a rough idea of what's going on, right? And the issue with the plain radiograph is that it can miss small lesions. So I hope everyone can see my arrow here. This is a plain radiograph. So we always compare right and left. There's a reason why I put a lot of silhouette on the left side. There is sometimes you can miss very small, tiny white dot in the left side. If you look at it on the right side also, there's a very tiny dots that sometimes you can miss them in the plain radiograph. But if the lesion is quite big, if something is quite big, then we can catch it up. So for example, in this particular image, we can also see there's something wrong in the upper segment compared to the lower segment because they have different in color. So in plain radiograph, we always have two different colors. One is black, one is white, and we call that opaque lucent. It's okay if you don't understand that, but when you look at the report, we always mention nodules and lesions, and I will come back to this later to explain what is nodule, what is lesion, and all those things. Right? So this is basically what is a plain radiograph. It's a screening tool. So you can do plain radiograph and miss small lesions, which can pick up by CT scan. CT scan is also using ionizing radiation, but as imagine you're taking a X-ray in 360 degrees all around you. And then I combine all this X-ray to form a 3D model of you. That's what CT scan does. Multiple view, you take X-ray in the multiple view and use computer to come up with a 3D model of what you look like. So that's why it's known as computed tomography scan, right? It gives you very good details and especially very good when you want to see bony structures, right? They look very nicely and you can actually see when there is an area which is abnormal or the area which is normal. So a normal lung, which is similar to the air outside your body, should be black in color. All right. So any other color that you have in the lung, there might be something wrong with it, except for we have some vessels in the lung which is not air containing, but anything containing air should be black in color. And we always love to compare right and left because it's very simple, because whatever is on the right should be on the left. With the lung, we have two lungs, so we just have to compare both sides. And for example, the image on top, you can notice that there is something not right on the left side. This is the left side. This is the right side. For radiologists, we do not look at a mirror image. We just imagine looking at the patient from downwards, right? So this side is always right, and this side is always left side. So we can see something is not right on the left side. Then we have to decide what is not right on the left side. So then we have what is known as densities. We have certain values for this, and based on that, we said, okay, in this particular case, this area has something, and this is in a water density. Then we said this is pleural effusion. That means water in the lung, right? So basically, we deduce based on what type of image we're looking at and what type of density. So X-ray works on dense. That means if something which is very clear, which is black color, it's air. That means all the X-ray went through. There's nothing stopping them from going through. So there'll be dark color. As they become more and more denser, they'll become more and more white. For example, bone is a very dense structure in your body, so bones will be white. So that's how it looks. Based on density difference, we can basically tell what type of characteristics are we looking at. Okay, this is more expensive than plain radiograph, and it contains more ionizing radiation. Therefore, CT scan is not commonly used for screening. In certain countries overseas, they tried to use CT scan as a screening tool for lung cancer. There are pro and con for this because they do catch a lot of small nodules at the initial stage. Therefore, you can do biopsies and you can screen the lung cancers early. But also, you're actually exposing the patients to a high radiation, which could lead to lung cancer in the subsequent years. So there are pro and con here. In Malaysia, we do not do this. We do not use CT scan to see lung cancers. We mean to screen lung cancers. But when we see something wrong in chest X-rays, sometimes we do CT scan to prove that this is normal or abnormal. I'll show you normal and abnormal after this, all right? So two reasons why we use it. One is to diagnose. Sometimes we also use this to look for progression. If I do treatment for you, I want to know whether your treatment works or don't work, right? For example, these two images, the one on top and the one below, is the same patient. This was initially how he came in, and this was after treatment. In this case, because I also worked with ECCT, the company which JRX, one of the products of JRX. So we worked on that, and we see after we give treatment, we want to see whether does it improve or not. We did another CT scan, and we compare it with the previous CT scan. We noted, okay, now right and left, there's something wrong on the left side. There's also something here. We call this lymph nodes, right? But when we look at after the treatment, we don't see the lymph nodes anymore, and we don't see the water anymore. That we're quite sure that our treatment is working. So that's how we use the CT scan for, right? Some cases we go one step more, where we do MRI. If you look at CT scan, this is the CT gantry. You have to sleep here, and then you go through that, and then this gantry, this donut-looking structure, will take images, right? Similarly, MRI will also have something similar, but it has a longer tube. But this uses non-ionizing radiation. That means it's much more better than CT scan in the sense of that radiation doesn't cause harm to your body. But that is a catch. They are more expensive. A lot of hospitals don't have them, or they have a very limited type of MRI. So there's very limited type of studies we can do with them. They use a longer time to make the image. For example, let's assume if I take a chest X-ray, I can do it in less than, in a few seconds. A CT scan maybe in a few minutes. This will go about, let's assume I just want to do thorax alone, maybe half an hour to 45 minutes to do one patient. So every day you have a very limited number of patients can do MRI, comparing to CT scans and plain radiograph, where you can do, hundreds, and maybe some cases in some centers, they even do thousands of cases, right? In and out, in and out, in and out. So you can do very fast, especially, and it's in MRI, each one machine, you can actually spend about 15 to 45 minutes to do just one part of your body, right? So therefore, it's not normally used as a screening tool. It's used as a final diagnostic tool. I'm sorry. Okay, it's a final diagnostic tool, and it's very good to see soft tissue, but we are not going to focus on MRI today because that's in lung cancers is rarely used, right? But we have cases where we use the MRI to see the lesion. This is the one we normally use for cancers, right? It's known as PET scan. Basically, what PET scan does is that it shows which part of your body have a nodule and whether the nodule is active or not active, in the sense of whether it takes up the medicine or it doesn't take up the medicine. Okay, so the medicine or tracer, what we call them, will go throughout your body and will be collected in areas which has inflammation, which has tumors, which has infection. All these areas will light up, and there is sometimes some differences in the activity. For example, tumor might give you a higher activity comparing to the infection, comparing to inflammation, but everything can light up. So when you light up, normally it's easier for your eyes to catch it. For example, if you look at that CT scan over here, the one above A, and you compare that with B, which is the PET scan, you can see there are some areas are light up. For example, in the ribs, this is the, as I told you, the dense structure. The white one is the dense structure. It's here doesn't look much, but when you do the PET scan, you can see there's something lighting up there, telling you that something is wrong in that particular rib. Or for example, even on the left, on the right side, you can also note that here there is nothing much, but exactly at that one point, there is something lighting up, telling you there is something wrong. Again, if you look at the chest, in the hilar region, there is also another area lighting up, telling you there's something wrong there. So what happens last time is that we only get this image, the 1B image. But lately, we combine CT scan and PET scan, what we call as PET CT scan. Therefore, we know exactly where the area is. So we just put this image on top of this image. Exactly, I can tell you which structure is actually giving you that tracer uptake, and we can focus on that structure. Therefore, we can actually know where is that area, whether the area is metabolically active or not. So we, in that idea, we say that most tumors should be metabolically active. So when they are active, you should be able to see them in PET scan. Does it mean that all tumors will be active in PET scan? The answer is no. Okay. Sometimes they are not active. So that's why we need to do CT scan, sometimes to see the growth, especially for those who are not taking up too much of radio tracer. Sometimes we focus on PET scan alone, especially when that tumor is the one which is very active. So we can use this to compare when you do the treatment. Again, we're going to go back to another patient. If we can look at it, this is the pre-treatment. The first image is the pre-treatment, and the second image is the post-treatment. You can notice that pre-treatment, it has a lot of areas which is lighting up in the spine. This area here is the spine. You can see a lot of areas lighting up in the nose. This particular patient has some cancer called nasopharyngeal tumor with bone metastasis. And then we see when we give them with ECCT and we give them chemo, and we see how is the changes after that. We noted there is significant reduction. So this is how we say whether the treatment is working or not working. If it's getting more, then we know that something is still not working and we need to adjust the treatment in order for it to be working. All right. So I hope so far you guys understand what is chest X-ray is, what CT scan is, and what PET scan is. Okay. I'm just going to go through a nomenclature because this is where most people get confused, because there's so many words in the report that they have no idea what does it mean. Okay. So I'm going to start with something. When you see in the report, there's a word called lesion and the word called tumor. And it so happened because our social media and our newspapers have used this word tumor so much that everyone thinks tumor means bad, right? There are a lot of tumors which is not cancer. We're going to go to this later, all right? So now first we are talking about what is the word lesion means, what is the word tumor means. Tumor means anything which is a growth. We call them tumor. So one of the best example of tumor is the warts we have. I know some people might have warts, which is something coming out from the skin and is an abnormal tissue. So it's a tumor, but it's not a cancer. Okay, you can live with the wart forever, from young to old, and doesn't cause you any problem. So it's still a tumor, but it's not cancer. All right. When you talk about lesion, is that I know that area is abnormal, but I don't know whether is it a growth or is it an infection or is it, what is it? I have no idea what is it, but I know it is abnormal. So to be on the safe side, I use the word lesion. Until I prove this is a growth, I'll use the word lesion. So basically, anything abnormal is a lesion. For example, a tumor is a lesion. But if I know this is a growth, then I called it tumor. So lesions can be anything like injury, abnormal areas because of this hemorrhage, blood vessels broke at that area, or there's some infection, something like vessels abnormality. All of them is called lesions, right? So that's the first thing that we have to look at the report. Second thing is that the word neoplasm. These two are actually, they use interchangeably. There's actually stands for this nearly the same thing, because most tumors are neoplasm, right? But you have to know that when you talk about, for example, cancers, they're not all cancers has a bulk, has a growth. For example, when you talk about blood cancer, there's no any growth. It's just abnormal blood cells, right? So then you cannot call them tumor. So we call them neoplasm, right? Another common example is that some gastric cancers, they only come as an ulcer. So when you look at them, they're just ulcers. But we know that they are not normal ulcer. They are very cancerous ulcer. So, but we can't call them tumor because there's no growth there, right? So that's why the word neoplasm comes up. That means neoplasm covers most cancers. Tumor is only for growth. But normally they're interchangeably used. Even in reports, sometimes you can interchangeably use them. The next word is cancer and tumor. All right. So I told you tumor, very simple. Any growth, we call them tumor. But when we think the cancer, then we know this is an aggressive tumor. It has a potential to spread to other areas and cause huge damage to your body. Then we call them cancer. Okay. So when you say something is cancer, then we're telling you something is not right. You need to do something about it. But when I say something is tumor, it can be safe or it can be cancer. It can be both. All right. And when we say the any tumor which is not cancerous, we use the word benign. Just to tell you that when you say benign, that means we don't think it will grow fast. It's not very aggressive. We think that it will grow over quite number of years. It might stay the same. Only thing is it's abnormal growth. But one of the best example is the warts that some patients might have. Okay. Then the word come to us called grade. And this is another area where people always get confused is stage and grade. What is tumor stage and what is tumor grade? They are not the same. Okay. When you talk about grade, we're talking about how aggressive is that tumor. When the tumor is likely to spread, is it too big, too small? How fast, how aggressive is that thing? Whether the thing can be 1 cm today, in 3 months, it'll become 5 cm, or another tumor which is 1 cm today, in 3 months, will stay 1 or maybe become 1.1. So there is some changes, right? So a tumor which grows very big, very fast, we call them high grade. A tumor slowly gets bigger or slowly stays the same, we call them low grade. This does not mean they are not cancerous or cancerous. They can be both. We just use this to say how fast they can react. Okay. And again, this is another reasons why people get confused, because the grading is the same. We use grade 1 to grade 4. So tumor grade 4 does not mean tumor stage 4. I'll talk about stage later. All right. Tumor grade 4 means very aggressive. Tumor grade 1 means less aggressive. Let's just say if you said in your report, this appears to be low grade tumor, that means I know that if I do next screening, I can even do it 6 months time. I can even do it 1 year time, because I don't think it will grow that fast. But if I say this is a high grade tumor, if I wait for 3 months, then it would have grown too big. So from the initial stage where you can still operate, just in a matter of few months, it can be not operable. So that's why the word grading becomes very important. For example, the image down here, you can see one tiny little area on the left side, very round, very similar color, all right? And we say very well defined, very benign looking. Then we say that this is less likely to be high grade. I'll say, okay, this is low grade. This is basically subjective assessment of the doctor. We have no basis to say that this is for sure will not grow. It's not like that. We think because of the appearance in such a way that we think this is a low grade. Or because the appearance looks big, they have different colors, so we know that these tissues are trying to grow faster. Sometimes they can see a lot of vessels coming in, that we know that this is an aggressive, because when the vessels are those who bring food, so anything bringing food to the tumor, we know the tumor have a tendency to grow bigger and faster. So that's how we come back with the gradings of the tumor. All right. Of course, we also have an idea when we do biopsy certain tumors based on what is the nature of the tumor. We can say they belong to high grade or low grade. Okay. But when you talk about tumor staging, all right, then it's completely different. So when you ask me, when patients come and ask me, doctor, my doctor said I have stage 4 disease. What does it mean? Or I have stage 1 disease, stage 2A disease, stage 2B disease, or whatever diseases stage they give. And I will tell them few things. Number one, you have to know there are a lot of different type of staging. And A lot of doctors use different staging, but we have some sort of uniform staging for most cancer. So when you say stage 4 lung cancer, and if you say stage 4 rectal cancer, they might not mean the same, right? There are some similarities in the sense of when you say stage 4, that means the disease have moved from one side and moved to second side. But it does the stage 2, stage 1s, stage 3s, they might be slightly different. Okay, and the reason why I said there's a lot of difference here is that a lot of people get scared when people say you have stage 4 disease or stage 3 disease or stage 2 disease, because they don't understand what is it, and they try to compare. My friend had a breast cancer, and he was stage 3, and this is what happened. Now I have a brain cancer which stage 3, but you say I don't have much time to live. So you cannot understand why the stages are different. There is a reason for it, because we use different staging. So the staging depends on where is it, what size is it, whether has it went to the nearby organs, or how far you have moved from one area to another area. For example, if the tumor starts in the lung but already spread to the brain, then automatically we know that this is a very aggressive tumor that already started spreading, so they have a higher stage. If they are just in one area, very small, very confined, then we know that they are in the lower stage. So that's why we meant by staging depends on these few things we look at, all right? And they have so many things. For the lung, we use these three we call T and M. Basically means tumor, nodes, and mets. Tumor means what is the size, whether it's big or small. Based on that, the bigger the tumor, the higher the grading. How many lymph nodes are involved, whether in the same side, opposite side, then the more nodes are involved, more higher it is. Metastasis, every time, nearly for all classifications, whenever a tumor moves from one organ going to the second organ, it always stage 4, right? From one organ, move to another organ is always stage 4. Right, across the board. But there are also stage 4A, stage 4B. I'm not going to confuse you with that. But whenever they say metastasis, that means that cancer have moved from one to another area. Okay. The word primary tumor, and sometimes they call this secondary tumor. That these are the words that we have to look at, right? Primary tumor means where's the original cancer, and how big is the original cancer. Why is it important for us to look at the primary tumor, especially when you look at the TNM stages? Is that, remember, M stands for metastasis. That means that is a different organ, but that wasn't where the disease started. In this case, if the lung cancer and the brain cancer, the T based on the lung cancer, not on the brain cancer, right? So N is the nodes, and M is for metastasis. We'll mention there is a brain lesion, but the T doesn't measure the brain lesion for the T, okay, because that will fall in M. Why is it important? Is that when we look at any types of tumor, to do any type of treatment, we always have to know where is the primary tumor from, because the treatment changes. So when you go to a doctor and the doctor says you have brain cancer, for example, sorry, not you, if anyone, he says you have a brain cancer, then it doesn't mean that it's one tumor. There are a lot of different type of tumor. Each one of it has a different type of treatment. But when the doctor said this is a metastatic brain cancer, then they will do a lot of other investigation to find where is the origin of that cancer. Because as long as you don't solve that, if you keep on solving that lesion in the brain, you're not going to solve the problem of the patient, because the new tumors will start to come up again and again and again. So you have to solve both primary and secondary. And a lot of times when you go to secondary, when you have metastasis, the treatment will involve something which goes throughout your body, systemic treatment, we call them. So in the cases of chemotherapy, or in the cases of immunotherapy, or cases of ECCT, they always look at general body, right? So multiple areas. If you want to go functional, a single area, when you look at primary tumors, then we talk about radiotherapy. They are very targeted to one area, right? Or photon therapy, they are very targeted to one area. Okay, that's why it's important to know whether it's one area or multiple area and where is the primary tumor is. So when you talk about stage, this is the common one. This is actually a misnomer used to explain that. But as I mentioned to you, every cancer has its own staging. For example, liver cancer is no more 1, 2, 3, 4. It's rather 0, A, B, C, D, right? And the B have B5, B6, B7. So you make it more confusing, but it's easier for doctors who are in that field understand what's actually going on, because we know when you're talking about B7 or B6, what exactly and how is the condition. And literally that's how we look at how much expected survival for that patient is. So we have a rough guidance. So for cervical cancer, they have other staging. When you talk about lymphomas, they have other staging. So again, I'm telling you that not all stagings are the same. So do not get confused with stages between tumors, right? For lungs, we normally use TNM. Okay. So next query is that when you look at the report, you look at this word called mass. Sometimes they use the word nodule. It basically means the same thing. Both of these are growth. Basically, the difference is the size. When the size is small, the doctors call them nodule. When the size is big, the doctors call them mass. That's the only difference. Right? Anything less than 3 centimeter, we will call them nodules. We seldom call them mass. Anything more than 3 centimeter, we call them mass. So literally, it's the same thing. All right. So again, we are going back to benign, malignant, and what is primary and what is secondary. So when you talk about primary, as I told you, this is the origin of the cancer. Metastatic means the cancer from another area come to that particular area. So when people say lung cancer, the first question that the oncologist will ask them is that whether is the lung cancer is the primary or lung cancer is the secondary, because the treatment is totally different. All right, and it changes a lot in the management size. For example, the image lower down, you can see one particular area of tumor, which is shown by the red arrow here. And you can see it has something where they call as speculated. So we call that this one nodule, we call them speculated nodules in a radiology term. Whenever we use the word speculated, it's always something not good. It means it's trying to grow out of that particular nodule. The signs of aggressiveness of that nodule. So we always suggest for biopsy, even it's very small, when we see speculated nodules, right? So, and that tend to be a lot of times to be a primary lesion. And that is the one that we try to ask them to do biopsy in and to see what is that. Secondary, sometimes they come with a lot of areas. Huh? You can see a lot of different types, and normally they'll be rounded in the lung. So they have the term cannonball lesions. So this is known as the cannonball lesions in the lung, or cannonball tumors, just like cannon, the balls in the cannon. So how does it look like? So you have multiple tumors all over the body, and so secondaries, they can be multiple. They tend to be multiple. Doesn't mean all cases. Some cases they can be just one, and then we do biopsy and turn out to be secondary. But primary is something like that. Okay, singular ones. Just to show you, when I say primary lung tumor, it does not mean one tumor. Okay, it has so many different type of tumor. All of this is known as primary lung tumors. And if we can see that, we doctors look at it, we know there is a percentage, and we know that who comes more with what. If you're a smoker, what is the type of cancer you commonly get? If you're a non-smoker, what are the type of cancers you commonly get? Although both origin from the lung, although both are lung cancers primary, but the treatment differs a lot. And also how the prognosis, how well you will recover with the treatment, also changes. Another example I just want to show you for the lung cancer, these are both primary. One is the non-small cell, one is the small cell. You can notice the treatment ways also different between both of these. The prognosis basically means in 5 years, how many percent of them will survive. When you look at in 5 years, how many percent will survive, and you look, and non-cell tend to have a higher survival comparing to the small cells. And this is how we decide whether this particular patient is suitable for certain treatment or not suitable for certain treatment, and what type of treatment, who needs to be operated early, who can wait to do some other treatment before coming for operation and such. So we decide that based on this. And how we know this is we do biopsies. So when we see something and we think is benign, normally we know that it's going to grow very slowly. And sometimes we say, okay, at this point of time, we don't need to do any biopsy. We just have to do CT scan, maybe 6 monthly or 1 yearly, depending on the size, depending. We have some protocol of what we tend to use, and what size and what we need to do and such. Normally, benign means they're very nicely, we can actually see them, their borders very nicely, there'll be one area, and very much, they'll be much more smaller. Anything more than 1 centimeter, we always ask to biopsy. Unless there is certain telltale signs, we look at it and we said, okay, these nodules don't need to biopsy, because if you try to biopsy, you're going to cause more harm. Other than that, most of the time we ask them to biopsy when it's more than 1 centimeter, or when we see that subsequent, imaging, the size is getting bigger, then we say we biopsy. Otherwise, we say we can have a look, wait and look, and then if the disease doesn't change over the years, it's quite stable, then we don't have to do anything, we just observe, right? And benign tumors, normally we don't have to worry much, except for certain areas. For example, if you have a benign tumor in the brain, then we know that although it's very slowly growing, there's no space in the brain for it to grow. So for it to grow in the brain, you need to press on the normal brain structures, and that causes problem. Because when you press on any structures in your brain, that part where it supplies, that part where it controls, might lose its function, and that causes problem. One of the major ones we always mention is meningioma. Meningioma is considered as a benign tumor, but when it grows and it grows and it grows over the years, for example, let's say it's over the 20 years, became in such a size that it presses the brain too much that we need to do something about it, right? But another catch is that some of these benign tumors over many years can sometimes turn to become cancerous. So in some cases, they said, I don't want, I know it's benign, but please remove it, because there's a very small chance. For example, if I say 3% chance or 5% chance for it to turn into cancer, that means 95% it will not be a cancer. But there is, let's say, 5% or 3%, depending on that area, depending on that particular tumor, then it causes a problem. Okay, so remember, benign tumors, whenever they say benign tumors, the doctor's telling that these are not aggressive, these are quite safe, you can actually observe them over years, and then if they cause any problem, then treat. Otherwise, you can just continuously just observe only. Okay, but when they say malignant tumor or cancer, then the doctor is basically telling you that this needed to be treated urgently. Okay, one of the benign tumors we commonly see among females is what is called as fibroadenoma. It's a nodule in the breast. When you touch it, sometimes you can move it. It doesn't stick to the skin. And some patients will have it for many years without any problem, fibroadenomas, right? And they can come with many sizes, many shapes. But when we do the screening, we know that this looks quite safe, all right? And a very tiny percentage of this can turn out to be cancer over 20 years, over 30 years. So then they have this potential to turn to be cancer, all right? But we always say them, you can just watch, and then if you see it getting bigger, then we do something about it. If it doesn't get bigger, then we can just observe it over period, because nobody wants to go to surgery, right? Frankly, so we tend to look at it. But the moment we mention is malignant, or we mention is a cancerous lesion, then we are telling you that whatever happens, this must be treated. Okay, and because they can really grow rapidly in matter of months or matter of half a year, they can grow double the size or something like that. So you have to be very careful, and you cannot delay. And they have a tendency to go and disturb other structures next to them, or they have a tendency to go through the blood vessels, moving from point A to point B. For example, once they go into the blood vessels, they can move from the lung to the brain. They can move from the lung to the liver, from the lung to any part of the body, because our blood vessels is like the highways of the body. Once you go in, you can go to any part of the body. Similarly, at the lymph nodes, the lymphatic system is also another highway which bring you to one area to another area to another area. But normally lymphatic is much more slower, and we know that which region it goes first, goes second, goes third, and we can actually follow it up, and we can see, okay, these are the areas that you should be going in. But blood is kind of difficult because you can go anywhere, right? So this is the typical report that we normally see. In this report, this is the report of a PET scan. So this is a patient with the breast CA. I'm sorry I didn't get a lung, but I just took one with the breast CA. So he underwent a mastectomy, is a removal of the breast, and this patient is actually another ECCT patient. So on treatment, so this is the initial one. What you all need to focus on is not all of this. It's just the last part called impression, or in some places the right is conclusion. We just look at that part alone, because that part will summarize all the findings that you have. Okay, for example, here they say this is the breast, which is the chest one, right? So the left breast, the right breast is removed, so only have a left breast, and the right chest both has no, the word they use, hypermetabolic. That means no activity seen there, so that they don't use there's no tumor, because as I told you, some tumor doesn't take up, so you don't see them in the PET scan. But you just mentioned, okay, in the PET scan, I don't see any signal change there, so I put no hypermetabolic lesions in the chest wall. But there are multiple bone lesions. So we know that this is from breast, now went to bone, so this must be a stage 4 disease, an aggressive disease, and it has multiple bone metastasis. Okay, and also they wrote that nodule. So I told you, nodule is a mass, just smaller in size, less than 3 centimeter. If you're going to look back at this nodule, they say intraparotid nodule. So we just look back, okay, here, the word intraparotid nodule, and they told you the size is 0.9. That's why they use the word nodule. If the size is 3 centimeter, they would have used mass. Okay, just by the size, they say it's a nodule, and there is some decrease in metabolic activity comparingly, and others are okay. So the bigger problem here is that yes, a lot of new metastasis in the bone. So after treatment, we just compare that. Again, the same patient, PET scan still done. They're comparing with the previous PET scan. Just look at the impression alone. All right. When you look at impression, they write that, okay, the chest is clear, the left breast is clear, there's no any activity. The bone metastasis, some went up, some went down. So we know that treatment is giving response, but not all positive. The others are the same. So that whatever treatment we are doing at this point of time, we know that we are going in the right direction, but we are not controlling everything yet. So we just have to either decide whether we need to change to a stronger medicine or just continue that. Okay. Another example, this one is the chest CT scan. Sorry, moving here. Here, I'm just about to finish. Don't worry, I'm not going to make it very complex. Simple. Then if you have any questions, we can ask them. This is the chest CT scan. So by right, anything less than 3 centimeters should be nodule, but this doctor decided to call it mass. So in the area, we actually, just like coordinates, we put them where exactly is the area, but we need to see only conclusion that gives us the summary. And the word speculated is what we don't like. Normally, we will suggest for biopsy, right? They say it's suggestive of lung carcinoma, and there is bone lesions. So basically reading about these two, I can tell you that this patient has a lung lesion and a bone lesion. So this must be stage 4. And the lung lesion looks very suspicious. So the origin may be from the lung, and the bone might be metastasis. And I always says, in these cases, we will ask you to do biopsy. So this is when the patients will come to me, and they ask me to put in a needle and take a tissue. Because last time what happens is that you need to do a surgery to do this. We have to open up and go in and take out the whole bulk, and we send to them. But if it turn out to be something benign, something infection, you don't need the surgery. So right now we do a lot of this. It's called biopsies. And actually, if you go to my Facebook, I try to see whether I can get it. Sorry, I stopped share. Sorry. Yep. Just give me one moment. I try to open up from there. Just now when I did it, was very fast. Here now I'm screen share. Sorry, somehow it's not allowing me to open it. Okay, somehow it's not allowing me to open it. But so I just go back to share screen. Apply screen here, share. Okay, I hope it comes out again. So if you go to, this is actually in my Facebook, but if you can actually look at it, you can see that how the things are done. It's quite simple, straightforward, where we put in a needle from outside using a CT scan. We can target it to the area that we wanted and take a tissue, just a very small tissues. And based on that, we know what type of lung cancer is this, and we can plan the treatment, right? So basically that's all that I want to share with you all. But if you all have any questions, anything, I can try to answer them.
Thank you, Dr. Chandran.
Yeah.
All right. If anybody have any questions, you can either type in the chat box or you can actually raise up your hand and ask here. Alternately, if you don't have any questions, you can just type any numbers or icons so that we know that everybody doesn't have any questions, so that we can end the sessions a bit early. However, after this, if you have any sessions after, if any question after this, you can either WhatsApp us, reach us by WhatsApp or email. Then we will get back to you again if you have any questions for Dr. Chandran after that. All right, I can see icons start coming in. Thank you very much. All right, we will end the session if there is no more questions, but if you think of any questions, you can always contact us. Thank you very much, everybody, and good night.
Good night, everyone.